All right, welcome everyone to today's presentation, the Measles Alert and Update for Prevention. My name is Marta Alvarado. I'm the Manager of Education for MCN and your moderator for today. I'm going to quickly go over a few housekeeping items. All right, so that everyone is aware, this presentation is being recorded. If at any time during the presentation you have a question, please enter them in the Q&A or in the chat, and we will address your questions at the conclusion of the presentation. Let's go on to the next slide. Attendees have the option to view the Spanish language slides at the top. Wait, is this is interpretation? Sorry. You guys can switch audios between Spanish or English. Just locate the globe-shaped icon at the bottom of your Zoom toolbar. Click on it, a little drop-down menu will appear, and from there you can select the language that you want to listen in. Let's go on the next slide. At the same time, you can also choose to view the Spanish language slides for this presentation by locating the tabs on the top of your Zoom screen. One should be labeled English for the English presentation. The other is labeled Español for the Spanish presentation. You can simply click on whichever one you would rather view. Next slide. This session has been accredited for continuing nursing and medical education. Just a reminder that if you want to receive your certificate of continuing education or a certificate of successful completion, you must be in the session for at least 80% of the time. And yes, we do check. And you must also submit the post-session evaluation. Next slide. And real quickly, just to be in compliance with our accrediting agencies, I'll go ahead and read the disclosure of relevant financial relationships. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Next slide. And I'll go ahead and quickly introduce our two speakers for today. First, we have with us Dr. Laszlo Medeiros as Chief Medical Officer for MCN. Dr. Medeiros is responsible for the oversight of MCN's clinical activities. He also serves as a subject matter expert for various community health topics, including COVID-19. Over the past 30 years in parts of Africa, Central America, South America, the Pacific Islands, and the US, Dr. Medeiros has served and treated thousands for wide-ranging ailments, including newly emerging diseases. Thanks for being here with us, Laz. And presenting alongside with Laz is our Director of Training and Technical Assistance, Renee Edwards. Renee began her career as a Peace Corps volunteer in Honduras, which led her to public health. She has worked at local, state, national, and international government agencies for over 20 years. Renee's focus has been on infectious diseases, disease prevention, control, and surveillance, and clinician and community trainings. She is bilingual and holds a master's degree in public health. And with that, I want to turn it over to our first presenter, Dr. Laszlo Medeiros. Thanks for being here, everyone. Thank you, Laz.
Great. Thank you very much, Martha. And welcome, everybody. I'm excited to talk to you today about a emerging or re-emerging disease, measles, something that we had control over a while back, and looks like it's becoming more prevalent both here and across the world. Okay, next slide. So we're going to talk about measles. It isn't just a little rash. Measles can be dangerous, especially for babies and young children. So I'm a board certified family physician, and I worked in South Central Pennsylvania for almost 30 years now. And in that time, I was also in Central Africa, where I was also a Peace Corps volunteer about 40 years ago, and South Central America and parts of Europe, where I've unfortunately have seen measles reemerge in various places, both for vaccine hesitancy and also in some places in the world where it's really just difficult to vaccinate because of various situations, both geographic and political in parts of the world. So unfortunately, measles is still with us, but in the United States, we were about to just say we don't have any measles in 2000. And since that time, we've come back to seeing measles more over the last decades. Next slide. So what is measles? Measles is a viral disease. It's called rubeola. The virus that causes measles is rubeola. It's highly contagious. It spreads very easily, both in the old and the young. To avoid getting sick, you should get a vaccine called MMR. So MMR stands for mumps, measles, otherwise known as rubeola, and the R stands for rubella. The other name for that is German measles. So MMR, mumps, measles, rubella vaccine. This is a vaccine that was first initiated around 1963, and a better version came around 1968. Those people born before that time most likely had the virus and recovered from measles, and they're considered lifetime immune. So if you had measles as a child and you're born, especially before the 1960s, you're most likely immune at this point. So we're talking about now people who haven't been vaccinated or people who have been under-vaccinated as more likely to get measles when an outbreak occurs in any part of the world. Next slide. So in the United States, in the last 2 years, you could see here starting in early 2023 all the way up to April of 2025, so quite current, you can see weekly measles cases as determined by the onset of the rash. You can see it was fairly low in 2023, started to get a little bit more prevalent in 2024, February, a little bit decreased in the fall and winter of 2024, and then really just started up in 2025 quite significantly here. So you can see the y-axis, 100 measles cases. We're getting to the 80 to 100 zone at this point in the last several weeks. So much of 2025 has seen something much more drastically different than the last several years in the United States. Next slide. So U.S. measles cases in 2025, we see a breakdown here of age 5 and under, and then 5 to 19 years, and then 20 years and over, and then unknown, and then who is hospitalized. So the vast majority of them are younger people, and you can see that the 5 and under are the most hospitalized, and this is why I think measles is most concerning for those who are very young. But you can see that patients get hospitalized at all ages, and it can be very, very serious. I work part-time as a hospitalist doctor also, and sometimes we have had measles cases coming into the hospital for respiratory support when it has included the lungs. But I'll get to that in just a minute. Okay, next slide. So in 2025, you saw that big spike in measles cases week by week. And so where is it most prevalent? Well, right now, there is an outbreak in Western Texas and Eastern New Mexico. And you can see that those are the darkest parts of this map of the United States. So Texas is over 250 cases. New Mexico is getting up there into the 100 cases. And then you can see some areas all around, including where I live in Pennsylvania. We just had a couple of cases just in the recent weeks. So you can see that it's distributed in all parts of the United States pretty much. And this is going to, because it's so contagious, I think we're going to be seeing it spread further and further until most likely all 50 states will be experiencing it at some point fairly soon. Next slide. So how does measles spread? So one infected person can sneeze or cough, and if they're in a closed environment, then if there's unvaccinated people in the same room with them, and within 2 hours of them sneezing and coughing, they are quite contagious and easily will get measles. So, because it's so contagious, 90%, that is 9 out of 10 people that are unvaccinated and are present in the environment of that one person who's sneezing and coughing will become infected if exposed. Wherever somebody walks around and coughs and sneezes, you would have a potential outbreak right there with 9 out of the 10 people who are in that area who are unvaccinated will become infected if exposed. Okay, next slide. So recognizing the symptoms. So this child, you can see here, has measles, and you can see a couple of different things. First, if you listen to this child, they'll have a cough and a slightly wheezy sound to their lungs, and then a runny nose, which we call coryza, and then watery eyes, conjunctivitis. So those are 3 C's. In English, we just say cough, coryza, conjunctivitis, plus fever. That looks like measles. So this develops 7 to 14 days after being exposed to measles. And it depends on the size of the child, the health of the child, and the amount of virus that it was exposed to. That's why there's such a variation in 7 to 14 days of symptoms developing. 2 to 3 days after these symptoms, you can often see tiny white spots inside the mouth called Koplik spots. And this kind of tells you that this is measles as opposed to some other viral illness that causes a skin rash. Next slide. So 3 to 5 days after the symptoms begin is when you usually get the rash. And the rash is usually red, flat spots, starting at the hairline or on the face, spreading downward to the neck, the trunk, the arms, legs, and feet. Sometimes you get them also on the palms and soles, but not always. The spots may join together as they spread, and it kind of looks like one big rash at times. And during this time that the rash spreads, the fevers may continue to spike up to 104 Fahrenheit. And the child can be quite sick. Next slide. So treatment for this, there are really no antiviral medications to treat measles, only fluids and clinical support. Sometimes if there is a large rise in temperature, you can put cooling blankets on to help, but the best thing is support with fluids. If the child can eat and drink, then give it orally. And if the child cannot drink, then we bring to the hospital and give IV fluids. The general illness care requires rest, nutrition, and staying hydrated. That's the basic part. Then we just hope for the best. Next slide. So, when do you want to visit the emergency room? Well, if a person with measles has a really hard time breathing and is breathing much faster than normal, that's a time to have a doctor check them. There's also signs of severe dehydration, which include a dry nose and mouth, urinating less than usual. And then sometimes when that gets to extreme dehydration, there's confusion, decreased alertness, severe weakness. For young children also, if they start to get discolored, they're not getting enough oxygen. There's a blue color around the mouth, or there's crying without tears. There's usual low energy and a severe loss of appetite. All these are signs that we now need some kind of hospitalization if it's very severe. It's important if you're going to the emergency room or to a clinic or to a hospital to call ahead and let them know that you're bringing someone with potential measles so they can keep you away from other patients. Sometimes there's a room for isolation In cases of a large outbreak of measles, they're usually tents outside of the regular areas of the emergency room or the clinic where somebody can see you, and they will dress up in personal protective equipment and check on you and make sure that this is what it is, that it's measles rather than something else. But this allows people to not spread measles by going right into the middle of an emergency room or the middle of an urgency center and spread the disease very quickly. Like I say, it's very easy to catch measles if you are going into an environment where other people are with you in a closed environment, closed room. Next slide. So measles do have complications as well. So for risk, again, we have those pictures of who gets hospitalized, usually children 5 or under. Some adults older than 20 years old also have a very bad episode of measles if they haven't had measles before. Pregnant women who can have problems with early labor and premature delivery and low infant birth weight. Also, people with weakened immune systems. So, if there's already some other disease, diabetes, HIV, or other things that are making the patient sick, this will also make this person much more likely to get serious complications of measles. The highest risk are for those under 12 months because they are generally not getting any MMR vaccine until age 12 months. So they're too young to receive the vaccine under 12 months. They're much higher risk of actually getting measles from their older siblings or from school or elsewhere. Common complications include ear infections, and about 1 out of 10 children get otitis media. Also, 1 out of 10 have diarrhea. So these are common, and especially if they're not eating and drinking and they have diarrhea, now it's time to get them to a place where they can have IV fluids to sustain them while they recover from this viral infection. Next slide. So more serious complications. So again, the serious complications are in 1 out of 5 unvaccinated people in the United States who get measles. They'll be required to be hospitalized. Again, we talked about lung infection. So pneumonia, 1 out of 20 children will get a really bad pneumonia. This is the most common cause of death from measles in young children. We do have antibiotics that we can give if we've diagnosed pneumonia through a chest x-ray and other evaluations. Again, during pregnancy, mother will be at risk for premature birth or low birth weight baby. More serious cases include involvement of the brain. So encephalitis, when the virus attacks the brain, 1 out of 1,000 can get this encephalitis, and this leads to convulsions and can leave the child deaf or intellectually disabled. For this, we often add steroids to the mix as well if we've diagnosed encephalitis in the measles case. And then death, 1 to 3 out of every 1,000 cases of measles die from respiratory or neurologic complications. So these are more severe complications immediately while you're infected with measles. Next slide. Some other measles complications are more long-term. One of them is called subacute sclerosing panencephalitis, SSPE. It's very rare. It's usually 1 to 10 in 100,000. It's a fatal disease of the central nervous system when measles is acquired earlier in life. And this happens with wild type, that is the measles disease itself, and not with vaccination. But it can develop 7 to 10 years after the initial recovery from measles. And it doesn't matter how bad, how severe the measles was, people can get this 7 to 10 years later. And you're also at that time a risk for this if you had measles before the age of 2. So the younger you are, the more possible this disease is. And it's really unfortunate because we can't do much about it. And this leads to death in about 95% of the time. It's a very sad thing. I've only seen one or two of this outside the United States, and it is very tragic. Another disease long term is acute disseminated encephalomyelitis. This usually happens 1 to 2 months after the infection, and it can lead to seizures. And again, it can lead to neurological disorders that you have to live with for a longer period of time. And the other thing that measles can cause, even after you've recovered fully, is a weakened immune system for up to 2 years of life after recovery. So um, this is a very difficult situation for kids who are, already trying to get through measles and all the other vaccine preventable diseases if families decide not to vaccinate them, because they're up against fighting a whole lot of other uh, childhood diseases, bacterial and viral, and their immune system is weakened for the next 2 years after recovering from measles. Next slide. So again, if you're going to bring your child or your loved one into the a health center, urgent center, hospital, ER, etc., do use some precautions so you don't spread it around. So give advance notice to the emergency room before you enter. Attend to a patient in the parking lot. Sometimes we go out from the emergency room and evaluate the patient right in the parking lot or in a tent just outside of the regular ER to make sure that this is not an enclosed environment where they can spread it very easily. And ask people making appointments uh, if there's potential exposure from others in that same family. The ER attending, the nurses and doctors will wear protective equipment at this time so that they don't spread it to others as well. Sometimes you make the diagnosis after the visit. Like I say, it sometimes takes a couple of days for the rash to come out. And so some people just think that they have some sort of upper respiratory infection or some kind of other thing that's not measles. And if you find out subsequent to that visit that it was in fact measles, you have to clean that area very well, do contact investigation with everybody who made contact with that patient, and make sure that you know who are the people who are vaccinated, who are the people who are unvaccinated, because we may need to give them emergent vaccination within 72 hours if they're unvaccinated. That is the staff and other family members who may be bringing this patient in not knowing that they have measles. Next slide. So the measles vaccine MMR we just talked about a little bit at the first slide. There's a schedule for this for children and adults, and I'm going to talk about contraindications as well. But it's usually given in the first 12 to 15 months of life as shot number one. And then number two is between 4 and 6. In cases where there's an epidemic of measles, sometimes you can cut that short. And if they were unvaccinated, you can give the first vaccine and then wait 28 days, that is about a month, and then give the second vaccine. So that's more of an urgent scenario, especially as there are outbreaks, as we see right now in parts of the United States. So if somebody's unvaccinated, you can give them emergent vaccination schedule that's a little more intense than the usual. Next slide. So MR safety and effectiveness. MR vaccines are the most reliable way to protect against measles, mumps, and rubella. The first dose of MMR gives you about 93% effective protection. The second dose brings it up a little closer to 197 effective to prevent measles. So this is very important to get both doses. And again, we do this in routine childhood vaccinations, but if people somehow missed it, then it can be given in a shorter interval as well. And both the American Academy of Family Physicians, to which I belong, and the American Academy of Pediatricians strongly recommends MMR as the best way, the most reliable way to protect against mumps, measles, and rubella. We've had experience with this now for over 60 years, and it has done a great job protecting our children from mumps and measles and rubella. Next slide. So in 2000, the US declared measles eliminated. And we thought at that point we had herd immunity because if 95% of our population has been vaccinated, it is really a hard, the measles virus has a hard time finding victims. So this is the best. Some people talk about getting measles and then hopefully recovering and getting immune that way. But as I just mentioned, there are so many different complications that can arise from getting the measles. And we saw these complications much more frequently in the 1940s and 50s. And thankfully, after the 1960s, we've had the vaccine. And so we don't see the complications of wild type measles much in the last 40 years or so. And now we're starting to see it again because some people choose not to be vaccinating their children. And so we're seeing it come back. Measles is always around. When we just are vaccinated, it means we're protected, but it doesn't just die and go away. It's still with us, and it will continue to be with us. And therefore, vaccination is the best way to keep it from hurting our children and our loved ones. Next slide. So post-exposure prevention, again, I talked about areas where people have a large amount of measles occurring in one place. So if an unvaccinated patient is exposed to measles, an MMR vaccine can be given within 72 hours of exposure if the following conditions are met. They're 12 months or older, they're not immunocompromised, and there's no allergies to vaccine. Now, for children under 12 months, so if an unvaccinated child over 5 months and under 12 months is exposed to measles, then gamma globulin can be administered. In some places now, in these very endemic areas where measles is now running rampant, they are starting to try to vaccinate children at 6 months as well. This is new, and I don't have much experience in that area at this time, but this is one of the other things that is being done. But for anybody who is 12 months and older, if you can get the MMR vaccine within 72 hours, they may not develop as intense symptoms if they were exposed to the measles, which usually, again, takes like 4 to 7 days to come out. Okay, next slide. So there's some prevention strategies, and I think, Renee, you'll be talking about this.
Yes, apologies. In moving around
Okay.
here in the deck, I had to get caught up. All right. Hey, everyone. Thanks for joining us today. And yes, I'm going to talk about some of the other wider prevention strategies that you may see happening in your community, you may hear about, or you may not have heard about before. So one of the big things is some of the things that they do in public health centers or departments, and that is has to do with reporting, right? So measles is a notifiable condition. That means it must be reported to the health department, either your local health department or the state health department, right? Depends on your state and how they organize things. But one of those needs to be notified, whether you've diagnosed it with laboratory or you're looking at it going, yep, this is measles. It needs to go in so that they can do the follow-up that's necessary. And so it's not just measles, it's lots of other things like tuberculosis, sexually transmitted infections, a lot of gastrointestinal illness like E. coli and salmonella. Those are all different conditions and a whole bunch of other ones that have to be reported and require different kinds of follow-up depending on what the condition is. So if you are not familiar with these kind of things, maybe check your state health department and see what their list is. It can vary a little bit from one state to another of what's required. And then the health department will potentially be doing a contact investigation. And that is something that they'll do. They'll call the family and they'll try to see who all has been around the person. Depending if it's a child, they'll talk to their parents. If it's an adult, they'll talk to them directly. And they need to try to find all the places they've been while they were infectious and who's been around them and try to get some support for those folks as well. So some of you may have experienced this with COVID, right? It's something that they do with tuberculosis. It's something they do with vaccine preventable disease. They do it with syphilis, lots of different conditions. So it's not particular just to measles. Next slide. Now, schools and child care centers are all required to report the vaccine status of every child that attends their facility. They also have to report certain illnesses as well, including vaccine preventable illnesses like measles, to their local health department. Then the health department works with the school to exclude unvaccinated children during the time they're susceptible to becoming sick after a potential exposure. So the amount of time that children are excluded is going to depend on the illness. It's usually 21 days, and that's true for measles, from the exposure and ongoing until the last case occurs, plus that maximum number of days, right? So it can be a long time that an unvaccinated child may be out of school if there's an outbreak in their school or child care. Next slide. All right, there are some things that people can do as well. A lot of the cases that we've had over the years in the United States has been through travel, right? People go somewhere where there's still ongoing measles more than in the United States. And so some critical things to do is if you're going somewhere and you know that that's the case, get vaccinated at least 2 weeks or more before you're leaving, right? So it can really be in your system and working well by the time you get to where you're going. If travel's less than 2 weeks away and you just realize that maybe there's a problem with measles where you're going or other vaccine preventable illnesses, still get a dose. As Dr. Madaras told us earlier, sometimes just having that dose may not prevent you from getting sick on that close of getting vaccinated and being exposed, but it may prevent you from getting very sick when it does happen. Right, so everyone who's 12 months and older should have at least 2 doses before travel, again, assuming you're planning ahead and you're aware of your risks and you want to take care of that and really be well prepared when you land somewhere. Next slide. After travel, then, if you haven't been vaccinated or you know that you may have had an exposure, is to really watch for those symptoms we described, or talking to your patients if you're working with them, to look out for the symptoms for 3 weeks. Again, that's 21 days of potentially that you could become ill after an exposure. So if you do start to get any symptoms, regardless of what it is, right? If you're ill, it's best to stay home and to isolate. There's that idea that a lot of people had to get familiar with during COVID, but it applies to other illnesses as well. So if you're sick, especially if you're having any of these specific kind of symptoms, stay home. You might want to call your doctor. And again, don't just go to the doctor, or don't just go to urgent care, especially if you're really sick. Don't just show up at the hospital. Call them ahead. Let them know you're coming. They may see you in the parking lot. They may see you in a different way, depending on the urgency and depending on the situation, right? So just thinking that you are contagious from 4 days before the rash through 4 days after the rash is gone. And we all know rashes don't usually go away instantly, right? So this is a little stretch of time when people are infectious. Next slide. All right, so some other things that you might do depending on the kind of activities that your clinic or your facility likes to do is, really engaging your community health workers, making sure that they're up to date with current things that are happening, like these measles outbreaks, and knowing that there's more and more of them coming up across the country, so that they are ready to engage with your patients in a way that really works for your patients. You can do some other health education for community members through your immunization system, and making sure that they're well aware of what's available, where they can get stuff, especially for low cost or no cost vaccines. Make sure that they understand how vaccinations work and that they're safe and effective way to prevent illness, right? And we'll go over some samples of materials you could use that we have available. You're going to want to debunk misinformation and disinformation. This can be a difficult conversation to have with your patients, especially some of their parents may not really want to hear some of the things you're saying. And I would just recommend, from previously managing the immunization waiver program in a county health department, is to just stick with the facts. Don't get into a deep discussion about it. Just let them know the things you need them to know and the options they have to go forward to try to keep their child healthy, and how that affects the rest of their family, the rest of their friends, the rest of the community. And hopefully sometimes those things can sink in, right? And change a mind. Once in a while it does. It can be hard though. But I just encourage you, it's not worth getting into an argument with someone. Just stick to the facts and, do your best. And then, again, getting appropriate educational material. You want things that are really to the point, that have images that are attractive. And we, again, will have some materials that we can share from MCN. And last of all, if you're in a position to do any kind of campaigning, or maybe you use social media with your organization, that can be a way to help get the word out to your community as well. Next slide. So one of the approaches that MCN tends to take when we're working with communities is trying to think about, what do people need to make an informed decision, right? They need knowledge, the actual accurate knowledge provided to them in a way that makes sense to them. They need tools. They need to have the things that will help them understand easily. So it could be something in written form. Some people like to get information that way. It may be something very visual. It may be something that you're talking to people, learning through listening, right? You give them the tools they need to get and make changes or take action to help their family stay healthy. Let them know their rights and responsibilities, right? We have an immunization schedule in the United States that's very specific, and there's a reason for it. And it's, built to get the most immunity out of our bodies at the right times, and then keep that immunity over life for all different age levels, and all those details are there. So some people may not be aware, especially if they've come from somewhere else that maybe has a different setup, if they've come from another country, or who knows what their background is, right? So make sure that you give them everything they need to really understand what's expected and why. And then just having other just general community resources where you can put these things in the mix and help people stay up to date on anything that's happening in their community. Next slide. So here I'm going to share just a series of materials that we have available on our website, or if you have any struggles finding them, you can reach out to us as well to get you the things you need. But, thinking about working with folks from the community, these are things your community health workers might use, going from the very basics of what are infectious diseases and how do they infect us, to more details about vaccines and how they work. Next slide. So here we have this abuela, this grandma, who's sharing, about what vaccines she's had and how they help prevent illness for her and keep her going. She would have had a vaccine for tetanus, for smallpox, right? Some of us who are old enough had smallpox vaccines. They don't do those anymore, generally speaking. Chickenpox, she wouldn't have had that. That's a new vaccine that I actually, I had to get chickenpox as a child. I was quite sick with it, right? But now my kids didn't have to do that. Polio, which was very serious, and now there's very few cases of polio around the world. There's vaccines for tuberculosis in most other countries, right? We don't do that here in the United States, but people coming from other countries will have had vaccines for that. And then whooping cough, right? And there's a whole bunch of other ones too, that we do regularly, that we do in childhood, that we do as adults. Next slide. So, here's some materials that can be used to help people understand their immune system and how vaccines then support their immune system, what's already naturally happening, and then boosting that and making it even stronger. Next slide. Here we have a sample that can be used to show sort of vaccines as an umbrella, right? Protecting people from the germs that could be coming at them. And, thinking about in this picture, I really like to point out there is a man on the left who has an oxygen tank, right? And thinking about when we get immunized, we not only protect ourselves, but we protect our family, our friends, and the general community from someone who may be too sick to get immunizations themselves, right? So trying to help people also see that bigger picture aside from what's happening just with them. And, there's lots of ways to do that. But again, many materials that are visual, really visual, helps people get the picture in the community. Next slide. All right, Migrant Clinicians Network also offers a couple other handy tools. We have a vaccine calendar that people can use for all the different vaccines that you might get at different times in your life. There's a comic book that has lots of images and really helps tell the story without having to get into fine print details of medical journals or things like that, right? That just aren't suitable for everybody. And so we have some really nice materials that you can use with community health workers or just having them available in your community. Next slide. Just here's another sample from there, again, encouraging both adults and children to get all the vaccines that are appropriate for them. Next slide. Here's a little close-up of the comic book. Again, really pushing the importance of adults also getting their vaccines. I know a lot of times we feel well and we think we're doing okay and like, why bother? Those are for kids, but they're really for everyone and really trying to encourage that. We will share, and I see someone's asking, we will share these materials along with the slide deck when we send some emails out. And then they're on our website, and if you have any struggles, you can let us know. Okay, next slide. Another great tool that Migrant Clinicians Network offers is designing your own community-based communication campaigns. So you can get in here and it gives you some really outstanding instruction and materials to use that you can change the picture, you can change the language, you can do a variety of things to help the materials really fit your community. All of our communities are a little bit different, so these are completely editable. And you can use them as you need that is appropriate for lots of different conditions in your community or in your clinic. Next slide. And this goes along as well with our Vaccination Is campaign, which you can tailor to whatever the condition is that you're talking about, whatever the vaccine is that you want to promote, getting that hyper-local set of materials that you can either print, you can put it on your social media, there's graphics that you can edit in English and Spanish. There's videos you can use and then templates that are just, it's all changeable for what you really want to do to make your community enjoy the stuff that you're putting out. Next slide. And lastly, I just have a set of resources here. On the left, you see I have a list of things that might be best for clinics and clinicians to use. And then on the right are some things that are set up specifically for community or patients that are available in English and Spanish that have a lot of the materials that we talked about today. And again, these are all clickable, at least as of today. Hopefully they stay clickable for a while, but they will be in the slide deck when you get them. And in a moment, we are going to move over into next slide. Yeah, here is the evaluation deck coming up here, and I just want you to be able to look at that. We're about to answer any questions that you all have. I'm just going to leave this up. You can use your QR code. We'll also drop a link in the chat, and it will go out as well with the email after. But I want to leave this available. Maybe some of you will take care of that while we're answering questions. And I open it back up to Dr. Madaris. Let's see what people have to ask. So a few things.
Thank you, Renee. That was great.
Excuse me, Dr. Madaris, before we jump into answering questions, let me just quickly go to one more slide, Sonia. I put the evaluation links in both English and Spanish in the chat, so check those out. And real quickly, let us know how MCN has helped you. Our funders really do look at all these things.